I've got a ton. Don't want to answer it here, but our licensure laws, cross-state licensure laws, how does the laws of interstate commerce apply? So as we think about that, I have the right to cross a bridge any place or a border to see a physician in any state, but somehow we limit that electronically. So just throwing that out there for people to think about. So can we get the questions up on the screen? So Steve, you want to take the first one in terms of do you use your own providers exclusively or use Amwell providers as well?
Yeah, that's a great question. When we started, let's see, about 24 months ago, our health system, CMO, had a pretty particular stance and really felt like we needed to provide our care with our providers. A lot of not taking anything away from American Well, but felt like it was a technology firm, now became provider. So at that time we felt like we were going to do that. So we ended up taking our own providers, getting them trained up. Now, how did we do that to try to not allocate the cost to having providers? We ended up operations 24/7, so we ended up taking a 2-hour position for several of our ACPs. They would take 2-hour shifts throughout the day, so they didn't disrupt their whole practice of patient panel, but was able to allow that to be kind of spread out through about 6 or 8 advanced clinical practitioners. But now if I was to think about getting into from an ROI perspective in regards to launching, it's really, you have to weigh the perspective. It is a financial allocation to use your own providers. I think if I had to recommend where telemedicine groups are with their own provider groups, they're pretty sophisticated. They've had a lot of training now. You might want to use them for a period of time until you get an established patient base or enough patients per day, and then take that back over if you're encouraged about to be able to provide your own providers within your own system.
Dr. Watson, you're up next because this question has the next most asks. Do you use triage type protocols to determine which patients you think may be appropriate for remote patient monitoring? There we go.
It's a great question, and Joe, I just want to respond to one of your comments that when you say you can cross a bridge to healthcare, as long as one of the governors hasn't closed it, you can cross it. So just
And New Jersey is part of the matrix. Not pointing anybody out.
You know, that bridge is huge. It's huge.
And terrific.
Yes, I'm in a hole here. You can't get me virtually. I neglected to say, I frankly missed this point, which is the most critical point, that if you turn on remote monitoring and put all the patients through, you'll have great adherence and terrible results because you put the wrong people through the program. It's classic systematic error. For each use case that we have a very careful triage program where you identify patients through a variety of factors. It can be through EHR-generated lists, care teams on the payer side, automatic care need tools that the health plan has, and also through provider clinics. So each use case has a wide array of identification metrics. And then what you do is you carefully triage them into who's actually appropriate, and then you enroll them. And this is really the heart of the value proposition for remote monitoring, is making sure that you have the right identification, identify as many as possible, triage them, and then enroll them. And then once you get in, we have very carefully defined remote monitoring pathways. And so each remote monitoring pathway has how long are you going to be in, what are the resources that you have and the vendor have blended onto their tablet, how do you manage the escalations and alerts. And you take that and you give it to the vendor for their pathways, and then you plug it into your call center. So it's a very careful balance between the identification, triage, enrollment, the actual pathway itself, and then all this gets handed off to the call centers. And One other thing that we've very carefully done is we've been redefining our interfaces with Vivify, our vendor, into our message router. We don't necessarily want to hook this up straight to one EHR because we use Cerner, Epic, Variant, Allscripts, and vMotion for interoperability. We want this as a part of our message router so it gets broadcast throughout our clinical systems. So we've actually spent a fair amount of time designing the interfaces carefully so that the data is widely available on all sides of the healthcare system. It's an excellent question. Thanks.
Thanks, Dr. Watson. The next one up is, in the direct-to-consumer world, if a patient is vacationing or working outside of their home state, should there be an exemption to most state licensure laws to allow that patient to connect with their provider in their home state using telehealth?
Well, that question says should, not is or would. So, I mean, a lot of people do view law as a bridge between where we are and where we want to be. So I applaud that person. Should there? Maybe, if that's what the state elects to decide. There is none in any state right now. About 5 states have an express exception for follow-up care. So I fly to Maryland, get surgery on my heart, fly back home to Florida. That physician can do follow-up care with me via telemedicine or otherwise. Some states don't. A lot of them don't. Has any state medical, I've reviewed like all the state medical board enforcement actions on all that stuff. Has any state taken action against a provider for clinically appropriate follow-up care in that type of situation on the basis that the doctor was not licensed? No. Are the state medical boards your only concern? No. Technically, if that individual in the example was not an existing patient and they were on a snowbird long-term vacation and they wanted to connect with you, well, especially if you're advertising services in the state where they're vacationing, you've really put yourself at risk there, and that's not consistent with the state licensing rules.
Okay. Let's see the next one. How are you able to bill for direct-to-consumer medical services delivered by telephone? And I'm going to assume that means a blind phone call. And the other follow-up, would that be for a brand new patient or for an existing patient? I mean, there's many ways to look at that question.
I can field on the reimbursement. Most insurance plans will not cover phone only. Most states with commercial coverage laws prohibit phone only. They call it audio only. So how would you bill it? The only way you could really bill it is through a self-pay arrangement, or if the employer is paying it as an out-of-pocket benefit or something like that under private contracting. Does that mean you cannot bill for it? No, it doesn't. Some states do prohibit audio only delivery of healthcare services as below the standard of acceptable care. Some states do not. Where is it more flexible? After you've already established your doctor-patient relationship, through in-person or video, let's say, or whatnot, then states give much more latitude for follow-up type of consults, whether it's through message-based or audio only. I think the people who are going to have more problems are those typically startups who want to deploy an arrangement where the very first kickoff of a doctor-patient arrangement is audio only or message-based.
Hey, Joe, it's Andrew here. One point to add to that if you get that equation wrong or miss, it's actually the physician license at risk. It has nothing to do with the organization. And so that's a bit of a third rail issue.
Yeah, I agree. And Lori, there's one question for you. Are the RAND study papers available? And if yes, how do we access them?
So I'm happy to supply them. I know some folks don't have subscriptions. Some of them requires affiliation with an organization, but I can supply them. And
email them to the
yes,
mobile app.
Sure. And there are 3 papers on our teledoc evaluation, as well as another one that we're preparing now on costs, which is what I brought up briefly in the talk.
Okay, does anybody have a burning question out there that's not up on this screen? If not, I don't want to stand between all of you and lunch. So with that said, a round of applause for the panel.